How do we treat postpartum depression? I'm Dr. Tracey Marks, a psychiatrist, and this is part 2 of a series on women's mental health. The first one was on postpartum depression, what it looks like, and how it harms your baby. This video is about how we treat postpartum depression, and this would be depression that occurs within 4 to 6 weeks of giving birth. What if you become depressed during your pregnancy? That's a different topic for a different day that I will cover, but this is about treatment after you've given birth, even if your depression started before you gave birth. For severe postpartum depression, there's a new medication that was recently approved by the Food and Drug Administration here in the U.S. called Zulresso. The generic name for it is brexanolone, and it's the first drug specifically indicated for postpartum depression. It's given as an IV infusion over 2.5 days or 60 hours. How depressed do you need to be to get this treatment? Probably suicidal or so dysfunctional that you're not eating or you're not sleeping, and therefore you're unable to take care of your baby. In the clinical trials, the effects of the new drug were shown to work for up to a month in some women, and that's just from that one infusion. It does have some serious side effects, though, that include excessive sedation and sudden loss of consciousness during the infusion. So because of this, it has to be given under controlled conditions, and patients and doctors have to register with a monitoring system. Another option for moderate to severe depression are antidepressants. Can you take these medications while you're breastfeeding? It depends. You should always discuss this issue with your baby's pediatrician for a second opinion, because there are factors that can make it a bad idea to breastfeed if you're on medication. And some of these factors would be things like if your baby has a serious illness or is in the neonatal intensive care unit for any reason. Another example would be if your child was born premature. In this case, the baby's organs may not be fully developed, and getting a medication through breast milk may be harmful. Most drugs pass through to breast milk. It's a much smaller amount than you're getting, but it's still some. And here's how that happens. This is how your breast looks on the inside. This is fat, and these are the glands that make the milk. And these are your blood vessels. These drug particles in your bloodstream move into the milk glands by diffusion. Diffusion is when particles in a concentrated environment move to a less concentrated environment. In this case, you can think of the drug as being crammed into the blood vessels with very little room to move around. The milk duct has plenty of room for the drug particles to move around and have more space. So the drug naturally moves from the crammed environment in your bloodstream over into the less cramped environment in your milk duct.
Oh, that's much better.
If you feel your baby's healthy enough to handle this drug exposure, the best choice is a medication with a shorter half-life. Drugs with a longer half-life can accumulate in the baby. Fluoxetine, also known as Prozac, has a very long half-life and has been shown in case reports to be detectable at pretty decent levels in the baby's bloodstream. I have a reference in the description of a study that talks about this. The researchers analyzed 57 studies and measured the blood levels, and they found the preferred medications for breastfeeding were nortriptyline, paroxetine, and sertraline because these drugs did not pass through to the baby in significant quantities. Now, this study was from 2004. They didn't analyze the newer drugs like escitalopram, duloxetine, vortioxetine, which is also known as Trintellix. So, are you able to take these drugs? Are you just limited to the 3 in that study? The short answer is no. You and your doctor have to review your medication options. This isn't a decision that you can make alone. However, a general rule for your doctor to follow is that you should use drugs with a short half-life. The half-life is the amount of time it takes for half the drug to leave your system. Most of the antidepressants have a half-life of a day or less, and these would include medications like paroxetine, sertraline, escitalopram, bupropion. Super short half-life drugs would be venlafaxine, which is 5 hours, and duloxetine, which is 12 hours. A caution about these drugs, though, is because they don't hang around very long, you can experience withdrawal symptoms if you miss doses. I talk about this problem in a video I did on brain zaps and antidepressants. Fluoxetine has a half-life of 4 to 6 days, and vortioxetine has a half-life of 3 days. So those medications should be avoided if you're breastfeeding. Even though sometimes we will use lithium to treat depression, you do not want to take lithium if you're breastfeeding. Lithium passes on through to your breast milk and can be dangerous to the baby. If you do need to take lithium, though, you should consider discontinuing breastfeeding. Something else you can do to lessen the effect your medication has on your baby is to time the feedings around the time when the drug reaches its highest level in your bloodstream. Let me show you what I mean by this. When you take the medication, the amount of medication in your blood spikes to a peak level, then gradually drops off as the medication is broken down. This is called the peak plasma concentration, or Cmax. The time it takes for this to happen is called the Tmax, and this can be an hour or two or several hours. If you take a drug with a short half-life, it's going to be at its lowest level just before you take your next dose of the drug. Its drug curve is going to look like this instead of this. So the best time to breastfeed would be just before you take your next dose or just after you take it. You can time your medication around your baby's sleep schedule. Now, of course, your baby is going to feed more than once a day, but if you know when your medication peaks, you can at least try and avoid nursing at that time. Any time before or after will still mean the level is less than it would be at the peak time. How will you know when your medication peaks? This information is readily available if you look up your medication on the drug company's website or on sites like drugs.com. But I'll have a breastfeeding guide for you that summarizes the antidepressants that we use here in the U.S. And here's how you would use it. Sertraline has a Tmax of 4.5 to 8.5 hours. That's a pretty wide spread. Let's assume for you that it's 4.5 hours. And for this purpose, you do want to assume the lower number. Also, we know that sertraline is the half-life of it is 26 hours, which means that it takes 26 hours for the peak concentration to drop in half. Let's say you normally take your medication at 8 a.m. If it takes 4.5 hours to peak, it will reach its highest level around 12:30. So a good time to feed your baby is just before and just after your dose. If your baby feeds every 3 hours, you could feed him at 8 a.m., then 11 a.m., then 2 p.m. The idea is to try and avoid feeding around 12:30 if possible. Now, this is just a suggestion, and it's not intended to be a prescribed schedule for you to follow rigidly. Also, if you end up feeding your baby around the peak time of your medicine, it's not a guarantee that your baby's going to have problems, but if you can find a way to minimize the exposure, at least it's worth a try. You should always watch for signs that your baby is being affected by your medication, and some of these signs would be irritability, poor feeding, and uneasy sleep. What if you don't want to take medication? There are therapy options, and the recommended treatments are interpersonal psychotherapy, and this may be especially effective in postpartum depression to help you transition into your new roles as a mother. There's cognitive behavior therapy, and this tends to be more helpful in people who have a lot of anxiety along with their depression. Bright light therapy is also helpful for regular depression outside of pregnancy, so the assumption is that it may also be helpful in postpartum depression. Electroconvulsive therapy can be helpful for severe depression. Any medication can have side effects for you, and therapy requires a time and financial commitment. However, despite these negatives, untreated depression has negative effects on your child's development. It affects the mother-infant bond, which affects your baby's stability. Also, researchers have demonstrated negative effects that continue past the baby stage and into the toddler and young child stage. Children of depressed mothers will have more problems with anxiety. So it's definitely an issue worth addressing early. Talk to your doctor about this. You can start with your obstetrician. Many obstetricians will treat depressed mothers. It's just a matter of recognizing the problem. For more information on recognizing the problem, watch the video that I did on postpartum depression and how it looks. And subscribe for more videos. They come out every Wednesday. See you next time.